Dr. Sajid, you can start.
All right, Udit. I was just waiting if...
Recording in progress.
Yeah.
Very good evening to all distinguished clinicians who joined in at a very challenging time of family time on a Sunday. Really appreciate to come together for a learning this particular evening. On behalf of Dr. Reddy's, I'm Dr. Sujit Narayan, representing the medical team, of course, in the sense that it's a great honor, first of all, to be hosting this meeting, partly because this is an absolutely educational 100% initiative that we do only once a year. Forum, the journey which we started 3 years ago, and we believe partnering with who's who of those clinicians who have dedicated their lives of building this specialty over the years. And this particular topic today on the aspect of trauma, the theme of which is articular and peri-articular. We are into the 3rd edition, and we're grateful to be partnering with the Trauma Society of India. And this particular CME has also been awarded one CME accredited point. And just a little bit of background and perspective, briefly, if I may. 2019, just before the pandemic hit us, I think we started with current concepts and controversies. In Hyderabad, we hosted around 350 orthopedic surgeons across 16 hours of sessions in trauma, arthroplasty, spine, arthroscopy, as well as orthobiologics. So that was how our journey started, with around 43 faculty. We should have done more than that in the subsequent year, if not for Corona. I think 2020, we did a digital way. I think that's how the world went, and cases and techniques, but we didn't restrict ourselves. We gave enough time in the digital space as well. We are really grateful for those who have continued the journey. In 2022, we just finished topic on arthroplasty, and here we are, where about 1,000 attendees had attended, and we're expecting a similar group of audience to be benefiting from the topic today. So with that brief background, really welcome you all. And for today's session, we have a very able chairperson. I'm sure most of you know him. There's no need of an introduction, but obviously we are very senior panelists today who will be joining us. And if I may crystallize the chairperson's intro onto one slide, and here it is. He's Dr. Sushrut Babalkar. He's currently the Chief Center for Joint Reconstruction Surgery, working at Sushrut Institute of Medical Sciences, Nagpur, India. And he also has a research center as well as postgraduate Institute of Orthopedics there. And obviously leading from the front, and the person responsible for taking this whole, ideating the whole trauma session today from the Trauma Society of India, to which he is serving as a president currently. And he also is a founding member of International OTA, as well as the vice president at NAILS, the National Association of Interlocking Surgeons. Obviously, this would not do justice to his overall achievements. With that, please allow me to at least tell the audience that he's of course the youngest orthopedic surgeon in the world to hold the MCH orthopedic degree at the University of Liverpool. So Best Paper Award, of course, from the British Orthopaedics Association, as well as the annual meeting in England, and numerous publications in national and international books. So with that, I think we welcome the chairperson to start the proceedings, give the context, and keep this meeting open. Over to Dr. Sushrut Babalkar.
Yeah, thank you very much. If you can unshare, let me share my screen. So first of all, let me thank Dr. Reddy's to take this up as a trauma-related CME. Forum, I have been associated with Dr. Reddy since last couple of years, and it's a pleasure for me to welcome all of you, my dear fellow colleagues. Straight to the topic. Today we are going to discuss articular and peri-articular fractures. I have been associated with by many faculties who have joined me in contributing their thought process last couple of years, the concept of articular and periarticular fracture management has completely changed. We have seen a sea change in management of these fractures. We all know that articular fractures which penetrate into the joint with the advent of CT scan, 3D CT reconstruction, we are able to identify these fragments which are intra-articular, depressed, displaced, and with multiple plating, multiple approaches, with the advent of more biological corridors through the soft tissue, we are able to attack them and fix most of these major fragments. So we are talking of absolute stability of articular fractures, wherein we encourage primary healing. So multiple plating to fix these multiple fragments is with what we think of today. And wherever these fragments are located, CT scan will direct us to the location of the fragment, to the displacement and depression of this fragment. And then it's a personal take whether you want to add bone graft to it. Most of the people are shying away from doing bone grafts because this is a cancellous bone. It's huge bone bank right there. So if you do raft plating, if you adequately elevate it, if you adequately support this articular fragment, there is actually most of the times no need of adding a bone graft trauma to this area, is what is the current thought process. Let's look at this particular picture, which is articular with a peri-articular extension. Now what we think of such fractures is the crux of the theme today. So CT scan will tell you the articular fracture. CT scan will also tell you how it has extended into the shaft, metaphyseal, diaphyseal area. It will tell you the amount of displacement. It will tell you the amount of depression, amount of damage. The articular surface has already happened. So prima facie, external fixator to let the swelling down, which will also act as a taxis or ligamentotaxis. What we have done here is two variable plate fixation. So one plate is shorter, one plate is longer, articular surface is reconstructed, and then external fixator is then removed. The variable longer plate also gives you axial as well as rotational control. 3 months down the line, 6 months down the line, 8 months down the line, and it heals into acceptable situation. Of course, this patient had a compartment syndrome, blah, 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 but the option chosen for skeletal fixation was a variable length multiple plating. What you also should see here is the oblique screw, which is the strut screw, which is used in this longer plate. Longer plate is important to avoid the stress risers at the end of two equal size plates if you choose. Let's look at another case. This is a case which I always show in most of my peri-articular fractures, because this is a case which has taught me a lot of things. So this was a fracture, intra-articular supracondylar distal femur fracture. The index surgeon decided to fix this with a very meticulously done reduction, very meticulously done plate fixation, multiple screws. But my dear friend forgot the biology associated. I am sure everyone agrees with that. So it went on till healing, and at one point in time, it stopped throwing callus, and then it started breaking. The plate started giving way, indicating some non-union at some of the comminuted fracture level. At this point in time, patient came back to me, and what I did was remove the plate, did a longer plate. But what I also did is added biology at the non-union side in terms of what you see on the medial side, corticocancellous iliacus grafts, but also a strut of fibula which acted as a medial support. So a strut of fibula placed intramedularly and a corticocancellous, more biological approach. That was a broken plate. And 16 months down the line, it has thrown in a huge amount of callus. Where I went wrong, what I should have done, probably done, and I could escape out of this situation is put in one more screw there proximally, because 3 screws is a norm, especially in revision non-union cases. But what I want to drive in here is against the conventional thought of absolute rigid stability, multiplanar, multiplate fixation in an established non-union. I have chosen here a different concept of stability, and that's what we will look at. What I have chosen is intramedullary fixation using a fibular strut graft, biology, iliac crest graft, and a longer plate. So I have chosen an absolute stability, a term which our good friend Kori Kojima has coined. So a combination of absolute stability and relative stability has worked in this situation. This is one of Sunil's slide, which I fondly show, wherein he chooses in difficult cases of medial comminution distal femur, he chooses to pass in this rush rod, which is his favorite. In some of the cases, I choose to do a medial plating. So the magic numerical is 6 centimeters of displacement or non-contact in any of the planes that you see on the medial side in distal femur. You need to throw in a dual plate option. So distal femur, peri-articular fracture, periprosthetic, very common. If you rely only on one side plate in this huge amount of comminution, which you need to look at on a CT scan, because AP and lateral will not give you an idea how much is the gap between comminuted fragments, and you need to define that to 6 centimeters. If it is 6 centimeters or more, your osteocytes, active osteocytes, will not jump that gap. So you need to support that. Here I have chosen to put in a nail, and these days nail I'm getting more and more fond of doing primary nailing and plating for all these revision cases, difficult comminuted cases. So the consensus is modern retrograde nailing is a good option for distal femur. Plating, when you respect biology and you respect and pay attention to working length. Medial support, whenever it's required, please do not shy away from it. Define that magic numerical of 6 centimeters gap and throw in a medial support. May it be a rush nail as Sunil uses, may it be a plate that I use, or may it be a centrally placed retrograde nail wherever you can. If you're not able to use nail plate combination, might as well use variable length multiplating. For example, in cases of distal humerus peri-articular, for example, in proximal tibia peri-articular with extension to shaft. Please have a combination of nail plate, plate in your armamentarium for these complex cases, because we are going to look at more and more complex trauma with increasing amount of high velocity injuries, with increasing increase in osteoporosis. So peri-prosthetic or peri-implant fractures getting more and more common. So let's look at our friends presenting some difficult cases today. I request all the faculty to restrict to time so that we can discuss cases, so that audience gets more and more from today's seminar and today's discussion. This is the article wherein Kori Kojima talked about absolute stability concept. He talked about this in primary difficult situations. I have borrowed the same idea to even revision difficult cases. This is a good read. So please remember this article and apply this in your clinical situation. Let's move on to our first faculty presenting.
Thank you, Dr. Sushrut, I think, for the for setting the tone and
Dr.
presenting
Chidar,
the newer advancements.
Sushrut, can I ask you a question here?
Absolutely.
The absolute relative stability is only for the fresh fractures.
I told when I ended that Odi Kojima described it for difficult complex trauma cases, and I've extrapolated the idea also for revision complex cases, and it's working. I showed you with the example.
No, that case you showed a broken implant of the distal femur, putting a fibular graft. The fibular graft is not giving you any stability on the medial side. The non-Indian, established non-Indian requires absolute stability, not absolute stability. It's all confusing yet to be concept to be not to confuse many people, because people are going to copy it, your success, but it is not going to happen that way. So I would have put the medial side plate again as we would do. So medial side plate, short plate, bone graft, and the long plate would have been the ideal. You are lucky that you got that union somehow, but that is not the concept of absolute relative stability on that non-Indian.
Okay.
And just one clarification from my side: is it 6 centimeters or 6 millimeters? The distance between the fracture gap.
6 millimeters. Sorry,
Yes,
did I?
because
kept
you
on
were saying 6
centimeters.
It is
6 millimeters.
Right.
Can I add on to that?
Sure, Chetan.
So there's a beautiful article by Wong et al. In Injury 2019, October again, where he has written a review article on failures of distal femur fixation. And there he says that if your medial gap is more than 2 centimeters, then you need to add something on the medial side, either ideally a plate or a stud bone graft like you did. But then that will not give you stability, like Sunil said. Sunil adds a nail. Not many can do it successfully like he does, but then yes, it seems to be helping. But something needs to be added on the medial side if your gap is more than 2 centimeters.
Yeah.
You can't rely on only one single plate.
So to pinpointedly tell what are the options so that audience learns from it. So the options are rush rod, ender snail, plate. Plate becomes a little difficult because it can be subcutaneous and you have to really look for the biological soft tissue sparing approach. Some people use metal cage. I personally love using a plate.
Yes.
The case which I demonstrated, Chetan, was a fibular strut graft long enough to be acting as, in fact, intramedullary nail. So it was absolutely snugly fitting.
Right.
But I completely agree with Sunil. The message in established non-unions has to be, as on today, absolute stability with multiplanar, multiplate fixation. There is no doubt about it, and bone grafting. So that's the sure shot way to success.
I'm going to show a similar case.
I want to ask, plate when? Fresh, at the day one, you will put 2 plates?
So what I do, I wait for 2 weeks and I go back in again. And at the end of 2 weeks, I put in a plate because I think on day 1, the whole knee, lower end femur is so swollen, so traumatized. You don't want to add trauma on the medial side also. So rush nail doesn't cause any trauma, but if I want to do plate, then I go 2 weeks later.
Sushrut, I'll just take the discussion to another side. What incision you prefer? Do you prefer the incision anteriorly, looking at it that all these patients may need a surgery by a knee arthroplasty at some stage? So do you prefer an anterior incision, the midline?
No, anteromedial incision, because this plate preferably has to be 90 to 130 degrees to the primary plate. Right. If you put it dead anteriorly, it's going to hamper your future total knee replacement. So that's absolutely a no-no. But there is a beautiful plane available anteromedially. You know, like a subvastus approach in TKR. So you pass the plate subvastus. You don't need a huge open approach. You just slide your plate and lock it distally, lock it proximally. It sits beautifully, snugly fitting. And now there are anatomical plates also available for this purpose.
Yeah. And what about the intercondylar tibial fractures? What incision?
Intracondylar tibial fractures is a completely different ball game. Multiple plating, multiple planes,
Right.
depending on where the fragment is located. You honestly, now I have realized after being a strong proponent of fixing all the possible articular fragments, now I am shying away. You don't really need to fix that tiny posterior-medial fragment, that tiny posterolateral fragment, if the patient is non-demanding on the knee. So if the patient is older than 55, 60, you can get away from those rim fractures, very tiny fractures. You don't need to fix them because you might do more harm than good. Most of these patients don't squat down, don't kneel down. But if you do that, you are going to hamper, as you rightly said, Rajiv, your future total knee replacement.
Right. Thank you.
So,
Yeah.
we had to interrupt the lovely discussion happening, but sticking on time, Dr. Sushrut, should we proceed? Or?
Absolutely. So, Chetan is next, right?
Yes,
Sir. Yes.
May I
Can we
request
have-
all the faculty, please go through the timetable. Do not wait for a special invite for your name to be called. Just barge in and start showing.
Udit, can we have the slides, please?
Yeah, Dr. Chetan, can we show intro slide for Dr. Chetan?
So moving to the next session, thanks for setting the context, Chairperson, I think, for the newer advancements, lovely discussion. For the next speaker, we would like to invite Dr. Chetan V. Pradhan. He's working currently as a consultant orthopedic surgeon, head of trauma and emergency services at the famed Sancheti Institute of Orthopedics and Rehabilitation, Pune, India. He holds several fellowships accredited from international renowned institutes, as well as is highly expert in organizing academic workshops as well as courses in various orthopedic topics. Very active faculty in various national and international courses on trauma surgery. With those several publications, of course, and also chapters in books, we invite Dr. Chetan Pradhan to start his next topic on difficult distal femur non-union. I hope I got that right.
Yes, thank you,
Thanks, sir.
organizers. Thank you, Sushrut. I'll share my screen right now. So,
Yeah.
so I'm
If you
just
could-
going to present a case more or less on similar lines what Sushrut just spoke about and we discussed. So this was going straight to the case. This was a 65-year-old diabetic gentleman who presented to me with pain around the operated site and the knee. He was 3 months post-surgery for a non-union distal femur. So this was already his second surgery. He had his primary fracture plated, which had failed, and the surgeon had redone it with plating. This was the X-ray, and he had also bone grafted. But the patient continued to have pain. He was 3 months post-op and he could not even bear any weight on it without walker. He was practically non-weight bearing. And because of the persistent pain and inability to load, he came for a second opinion to us. And this was the picture. Now, anyone from the panelists, what should be done at this stage? Sunil, Sushrut.
Chetan,
Yes.
this was 3 months old
Yes.
and
This
patient
was
still
an
has pain, is it?
operated non-union, 3 months old, and patient just not able to load it
Okay.
at all.
So obviously you are heading for trouble, right?
Yes.
Because there is a huge gap which you see medially.
Right. Though it was bone grafted, as you can see from the lateral X-ray, there are some bone chips from corticocancellous iliac crest seen, but the patient was just not able to load at all.
True. So if, as I did, if there would have been an intramedularly placed fibular strut or extramedularly placed plate, probably it would have worked, is what I think. So two things, Chetan, I want you to bring out in this case for the sake of audience. Number one is do a CT scan, because CT scan is the surest way of diagnosing if we are dealing with non-union. And CT scan also will give you all those variable planes And what you really need to do is not a CT reconstruction, but CT tomograms, so that you can see that plane of cleavage and
so 2D CT.
2D CT, correct.
Yes, you're right. I told him to wait because 3 months was rather early to comment on whether he would progress to union or not. True. There were no obvious signs suggesting any infection at that point of time. So I said, let us wait, start toe-touch weight bearing. I was contemplating giving teriparatide, etc.
Sunil, what would you do?
I think there is no point in waiting because he has put so many screws. The length is shorter.
Right.
There are holes of the previous removal with the loosening of the plate of the screws become loose. So I would have gone into directly the change and this plate, bring the longest plate available till the lesser trochanter. And now, as it is an extra-articular, now the intra-articular extension, whatever the previous fracture, it must have healed.
Correct.
Intra-articular part must have healed.
Right.
Then I would have used a nail and the plate combination, because this is very, very important, because already bone grafting is already been done. So we don't want to disturb, like putting again a plate. Again, whatever the bone healing has already, it will start some healing. But what it requires is real absolute stability, and that is a nail and the plate is a super combination for such fractures where you are not sure about the hole which you want to put on the medial side, which will not get any access to the medial cortex.
Because so Sunil, can I ask you something, Sunil?
Yeah.
Would you do bone grafting, yes or no?
After 3 months, again?
Yes or no? Yes or no?
Again, no. Again, no.
You should do bone grafting because your so-called super combination is not going to throw in bone callus. You need to add biology
to your it is super already done 3 months back.
Yeah, it doesn't matter. It is all dead now.
There is no stability. So you give a stability.
Absolutely.
You can add some chips from the tibial tuberosity, but I would
you need to do both. One more comment, Chetan, if you allow me.
Yes, of course.
See, you see the plate. It's a Zimmer plate.
Yeah.
Right.
Pain 3 months down the line, I'm tending to agree with Sunil, because if you wait, it will go into frank non-union. You and me, we know how strong Zimmer plates are. It will never break. Right. Not never, but it is a very tough implant.
Yes.
Distal femur Zimmer plates are very tough implants to break.
Right.
So it will go into non-union without plate breaking,
So
okay. So what did you do, Chetan?
I told him that...
What was the range of movement in this patient at the time of 3 months?
So hardly any range of movement because there was pain. The patient had
that's
pain.
what expected, right?
Yeah. So
So nailing will be difficult.
No, that's what I asked first question, whether how much the movement. If movement was not possible, then passing a nail will be extremely difficult.
Yeah, basically, there is a biological and mechanical failure both. So both the things should be addressed.
Right.
A longer plate, a medial plate, and a bone graft.
Of course, the less range of movement could be attributed to pain as well. But then I told him that if he does not progress at all in another 6 weeks, then probably he'll need another medial plate and more bone graft, like what Sushrut suggested. So that was my take on it. He went home.
So you want to say you have planned only the change, put on the medial side?
No, I would have revised this to a longer plate.
This longer plate, shorter plate.
Yes. So bicondylar plating with repeat bone grafting was my plan. If he did not progress at all, or if his plane did not reduce. So he went back. He continued to have pain. He did not come to me for another 3 months more. But now he presented at 6 months again. So 6 months post non-union surgery. Now he had a mild warmth. X-ray was more or less similar. The bone grafts had resorbed. The counts were raised. The CRP was 65. His HbA1c was 10, suggesting uncontrolled diabetes. So this was the presentation. So the pain was probably lingering low grade infection. So I suggested, though there was no frank discharge from the wound, but there was warmth. So I suggested him that we need to remove this, debride it, send cultures, give antibiotics, control diabetes, etc. Any other thought on this?
Do you send Chetan all these implant wash for the culture and the extended culture?
No, I send the tissue beneath the plate for culture.
Okay. In my practice, what I find useful is that implant wash, if you send,
right,
that usually comes positive, and that's surprisingly in many of these non-unions, there is a presence of some low-grade infection, these less virulent bacteria, which is a problem.
So you mean to say the biofilm you are sending?
I send the biofilm. Yeah, I send the film below the plate. You always have dirty granulation and a film below the plate. So that is sent for culture.
So I'll tell you, Chetan, since Rajiv asked, I have two protocols. My protocol for joint replacement is different. I send them for wash, and they can harvest from the biofilm what bugs can be grown. So that's for arthroplasty setup, because patient is spending huge amount of money. Once infected arthroplasty, it's gone.
Yeah.
Trauma, number one, patient doesn't want to spend that much money. I mean, that's a fact, whatever it is. Number two, somehow lot of inference cannot be drawn if the patient is already diabetic coming to us with a long-standing infection between 3 to 6 months. So the protocol seems to be different in trauma, but I agree with Rajiv. Again, one good insight and a thing which we have learned is even in trauma, we should do this cold wash technique for sending the implant, and maybe add on later to antibiotic, which comes.
So you're suggesting send the implant for a culture?
Implant. What they do is they take the implant and the biofilm which is on the implant, they grow culture and sensitivity from it. Okay. So that's a routine in arthroplasty. We never do it in trauma. I am sitting on the fence doing both, so I know both the worlds. My own protocol for trauma patients is different.
See, the advantage it's advantage of sending the implant wash, which you can do it on the table itself. You put a plate or the removed implant screws in one tray, a larger tray, and put about 10 ml of saline with a little bit of force, jet kind of a effect. And then let it be there for 10 minutes. And then you take out the 5 ml or 6 ml of the fluid and put it in the backpack bottle. So the advantage is that you are putting it in the culture, following all aseptic precautions. You are not actually subjecting it to the possibility of contamination. And culture it for a period of extended culture for 2 weeks if the bacteria is not growing. That we found very useful in our practice.
Yes, the backtech idea is great. I mean, we also follow it at times that we straight on send the body fluid or the wash fluid straight away into the backtech bottle. So
at our institute, we use a process called sonication. So all our implants, whether it is trauma or arthroplasty, we pack them in a sterile box and send the whole implant to microbiology, where they use sonication using ultrasound. And that gives a high yield of things. And where all the cultures are negative, usually we get a bug from the sonication of the implants.
Very right. That's a very good way.
Yeah. So I told him that we would debride and remove the implant. Again, he somehow went to the index surgeon, and for some reason, the index surgeon did a partial removal of implant. I don't know why. The notes written on the case paper were debridement and a partial implant removal.
There is a loosening of the screws.
Yes.
You see, the wind viper sign was positive.
So I think he did something like a dare. He retained the implant, and probably because the X-ray was showing some signs of union, so he wanted to keep the implant. But the pain continued, and at this time, now this was, mind you, his third surgery on the same site. At that time, he presented with discharge from the surgery site. So now he had a frank discharge coming out. And I told him this is not going to settle unless we remove everything and do a formal proper debridement and culture-specific antibiotic for a long time with the help of an ID specialist. And that is what I did. So I removed everything, I washed it, and this was the situation. Antibiotics were given for a very long time, like all the IDs do. And at 2 months, he presented with a dry wound, and this was his X-ray. However, the patient was not willing for another plating because 2 plates had failed, or a ring. We had given him 2 options that we will open and see. If I find the tissue not very healthy, we would go for a LRS kind of a fixation or a ring fixator. Or if the tissues were good, then I would end up plating it. But it would require a bicondylar plating and bone grafting was my plan for him. But he was not willing for another plate or a ring. Now what do you do?
Antibiotic nail.
You mean a retrograde antibiotic nail?
Yes, that because that's probably the least option, and it is central thing. And also you can put on some antibiotic beads on that, and you can nail it because the bone quality is too poor now. It is beyond this bicondylar plating. The screws are not going to hold. And I think even with the 0 degree motion at this point of the so osteoporotic, even if you do the Elizarov or your this thing, it is with this HB1 10 around CRP and everything shooting. I think Elizarov and LRS is also be very painful for the patient.
Right. So that's a good idea, Swarnendu.
But how do you put a nail because your knee is stiff?
No, stiff means you can't flex is like 15 degree, like you cannot even in anesthesia if you are opening it. Just to opening it the fracture side, because you have to open the fracture side whichever way. You can put the nail in.
So you do an intra-op arthrolysis and then get some movement to put in a nail.
You have to somehow open the whole thing, freshen up.
Right. Fine. I did not take your advice. Then I should have. I did not do a antibiotic nail at that time, but that seems like a good idea. And so he went back and now this was the 2 months X-ray. At this 3 months X-ray, I'm sorry about that. But then 1 month later, it was all dry. There was no local infection. The labs seemed normal. And I was more keen for a internal fixation. So antibiotic nail would have been a good idea. But this is what I did, what Sunil was saying. So I put in a retrograde simple nail, not an antibiotic nail. But I augmented it with a lateral plate only and added more bone graft from the posterior iliac crest. And this was the fixation. Any comments on this?
Could you convince him for plate now? So nail plate was okay for him. Only plate was not.
No, I told him that your main thing will be nailing. But if I find the bone quality very poor, I might add an adjuvant plate to it, depending on how your bone is. So I knew that I could blame it on his bone quality. But he was not willing for that kind of a plate. So I had to use a DCP like.
This is great. This is absolutely terrific.
Yeah.
But Chetan, my question to you is, could you have avoided a frank non-union as you saw if you would have attacked him when he came to you first 3 months later, 3 months, that milestone?
Yeah, probably that was the time when I should have done this.
Yeah.
But then
it's a difficult one. I completely agree with you.
Yeah, another possibility was that at that time itself he was having a lingering infection. So
yeah, sure,
probably
absolutely. Any questions, Sudhir?
Chetan, the 2 questions to you.
Yes, sir.
One is that did you remove the part of the avascular bone at the non-union site when you fixed it?
Yes.
Done, right?
Yeah, you are very right. It was more shortening than.
Yes, just wanted to say for the sake of the audience that improving the vascularity is a very good idea. Without that, all the efforts are useless.
Right. If you see the lateral, I have taken a socket there.
Yes.
I've made it transverse. I have put in the nail and I have done a rigid dynamic compressive fixation. Yeah.
And at the time of the surgery that you did, did you find that the infection had totally was in control?
Yes, because I had waited for 3 months. We had given him, he was already on IV antibiotics, something like meropenem, targocid, etc. The IDs.
So this patient is 65.
Yes.
Would any surgeon on the panel will think about the knee arthroplasty in such a situation? When you think that the knee is the infection is under control?
Excellent question, because that is what his son asked me. Can you replace the joint? But then with presence of already history of infection, nobody in my hospital was willing to take that risk.
Correct.
Yes, that's very understandable. Right.
Yeah.
Chetan, I have a question.
Yes, Srinivas.
Yeah. So which one is first, nail or plate?
The nail first.
Always.
Always the nail first.
And plate is always a miss a nail technique. Okay. So let me put a stop to Chetan's case. Chetan, excellent job.
One slide. So this was at 6 months and this is at 2 years. And if you see, he's got 90 degrees of flexion as well.
Excellent.
Great
job, Chetan.
Great.
Thank you.
Perfect. So I think message from Chetan, your case is maybe look at infection as the cause of pain and establishing infection and non-union at 3 months down the line. So keep look out on that. Number 2, a combination of soft tissue culture along with sonication. Probably we should consider as trauma surgeons, because except for Rajiv, every one of us here basically are trauma surgeons, and we have never applied doing plate or implant sonication along with soft tissue biopsy. And I was just going through references parallelly. What is the efficacy? So combination of sonication and soft tissue biopsy is the surest way of diagnosing what bug and what antibiotic is to be given. Okay, so let's move on to the next case. Thanks, Chetan. Stay around so that we can have good, lively discussion continued.
Sir, one question can I ask?
Yes, Srini.
So what percentage of our cultures are positive?
In my books, 5 to 10% only, because by the time we do the culture, patient has already received huge amount of antibiotics from the index surgeon, from us, everywhere. So but still, it is better to do that, because there might be some trace of bacteria which is not grown, which is responding to these so-called higher antibiotics today. So it's worth doing it anyways.
Can I answer it?
Sure.
So Srini, to improve your percentage of positivity in a culture, what we follow is to stop the antibiotic completely for a week. Don't give the antibiotic however bad the discharge is looking, and send the biofilm below the plate or these new techniques which we use, and send it in a backtake bottle and do an extended culture. So what we do is usually wait for 48 hours, then 1 week, but then something grows if you do an extended culture, and that is usually positive.
Excellent. But
Rajiv, you wanted to suggest something, Rajiv? Quick, please.
Well, I follow that 2 weeks we stop the antibiotic.
2 weeks. Okay. So Chetan stops it for a week. Rajiv does it for 2 weeks. Good to go. Thank you very much. So let's move on. Deepak Agarwal is the next.
Dr. Deepak Agarwal, we request you to please present the next case. Dr. Deepak Agarwal joins us from Arogya Hospital, Raipur, and he would like to present on pediatric orthopedics in trauma. Dr. Deepak?
Yeah. Good evening, everybody.
Over to you.
Good evening. All yours.
So, we'd like to discuss about supracondylar fracture and non-union.
I think Dr. Deepak, your voice is a bit...
Deepak, can you close down your video? Just show the slides. We are good with it. Close down your video, please.
Sure.
Yeah, maybe the bandwidth. You can close the video, Dr. Deepak, for the while and continue the slides. Udit, team, can you please guide?
I think sir is finding some...
Dr.
Deepak sir, I request if you can switch off your video, it will be helpful for your signal part. Dr. Deepak sir? He's finding some issue in the signal part.
Udit,
Yes, sir.
can our DocMode team technically support him? In the meantime, we move on to the next speaker, please.
Yes,
Sure, sir. Sure.
Please unshare his and let's move on to the next one.
Can we get the slides, please?
Yeah. Dr. Jyoti, can you just show the slide?
Who's the next?
The agenda slide, please. Yeah.
Samarth, you are next. Suprapatellar.
Yes, sir.
Yeah. Dr. Samarth Mittal for the
Yes, sir.
next
Go on, buddy.
speaker. So Dr. Sumarth joins us from AIIMS, New Delhi. Just allow us to, I think he obviously, major achievements in his short span of his career. We just like to welcome him. He also holds the Limca Book of Records for conducting TKR at the highest altitude in 2013. Dr. Samarth, over to you.
Thank you. Over the next few minutes, I'll try to cover up something on suprapatellar tibia nailing. First of all, I would like to thank the organizers, Dr. Reddy's, especially Dr. Sushrut Babalkar for giving me this opportunity. Whenever I present the work of my team. So thanks to my mentor, Dr. Vivek Trikha, and my residents who helped me do these cases and help me prepare these talks. So the only difference between suprapatellar nail and all the other nailing techniques is that suprapatellar nailing technique can be done in extension, while all the other techniques require some amount of flexion. And that in suprapatellar nailing, making the entry point is almost automatic. You don't need to do anything much to make an entry point. How to control the trajectory in both coronal and sagittal plane becomes really, really easy when you're doing this in extension. The reduction is very easy, and the fluoroscopy also becomes a very simple thing, and there is no challenge in doing this. However, it is noted that if there is a tight patellofemoral joint, then it can be a problem, but I've never faced this opportunity. I've never faced this problem. Some people say it has a small learning curve, but I don't agree with that. And there are a few papers supporting that as well. But yes, it does need special jigs and equipment. And unless you don't have that, you cannot do a suprapatellar nail. And there are n number of papers which show that there is no difference in knee scores or outcomes when you do either a suprapatellar nail or an infrapatellar nail. And some people think that if you go through the knee, then there is a chance of doing infection into the knee. But in this paper, they've discussed 139 open tibia fractures where they did a suprapatellar nail, and none of these patients had septic arthritis. And in my practice, I've also not seen any of the patients having a knee septic arthritis. And in this paper, which talks mainly about distal tibia fractures with a nail, they say that biomechanically reamed nail is better than an unreamed nail, which is better than a plate. So those difficult distal tibia fractures, we are very normally plate for ease. If we can do a nail, especially with a suprapatellar technique, then that is biomechanically stable. And this has only happened because over the years, the amount of the type of nails that have come into the market with multiple proximal as well as distal locking configurations, better Herzog bends, as well as threaded screws that go onto the nail and lock onto the nail and don't come out. These are multi-directional screws, and these are the things that is why we are able to nail these cases. So starting with a few cases, this is a segmental tibia fracture, which can be a challenge with the normal technique. But with a suprapatellar technique, it really becomes a piece of cake. This is 3 months of follow-up. This is 6 months of follow-up. A type 6 tibial plateau fracture, which without the suprapatellar nailing technique cannot be thought of, can easily be nailed if you have a... Yes, sir.
Your slides are not moving. Put it on slideshow. We are not able to see your slides at all.
Sorry, sir.
Okay, that's okay.
So,
requesting full screen.
Slideshow, full screen, slideshow.
Sir, actually, I think the problem is in slideshow, they will not move. Are they moving now?
Yes, we can see the movement.
You have jumped a couple of slides, but that's okay. Don't worry. Show us the case. That's so important.
So this is the case that I was talking about, a segmental fracture where I have done a nail, which becomes very easy with the suprapatellar.
Nahi dikh raha hai, dost. Nahi dikh raha hai. Nahi dikh raha hai. Put it on slideshow. Go to that slide number 8 and put it on slideshow so that we can see it.
Yeah. Correct.
Should I go to slideshow now, sir?
Yes, please.
Now can you see the slide, sir?
No.
Sir, I'll just stick to this mode then to save time.
Okay, that's fine.
Okay.
So, fine. So, segmental tibia fracture can easily be nailed using this technique. This is 3 months follow-up. This is 6 months follow-up. A type 6 tibial plateau fracture, which looks really bad and we normally don't think of nailing, but can easily be nailed using the suprapatellar nailing technique. It requires a little bit of manipulation, which can be done closed, and a very difficult fracture with a very bad soft tissue condition can be nailed early with the minimalistic implant without the need of any special implants or 2 or 3 plates. Another case with a neck femur, shaft femur, and proximal tibia fracture. This one having a difficult type 6 tibia fracture going onto the shaft of the tibia. Can also be easily nailed. Earlier, this needed 3 plates, one on the posterior medial, one on the anterior medial, and one on the lateral side. But with this technique of suprapatellar nailing, all we need to do is reduce the fracture closed, put in a few K-wires. One has to be careful that when you put in these K-wires, they have to go posteriorly so that it doesn't alter the entry point. And then in the same position with some traction, one can start the entry point and do a nail. And once the nail goes in, everything gets locked. The locking screws of the nail, which are threaded onto the nail, hold on to these fragments. But if one still needs some extra stability, a few cannulated screws can be added on top of the nail to get these X-rays in a very bad looking fracture with the cheapest and smallest of implants. And this is how the post-operative X-ray looked for this patient. He also had a shaft femur fracture with a neck femur fracture, which was fixed. And the patient had a good union, and this is the 6 months follow-up of this patient having good union. Another type 6 tibial plateau fracture, the same technique, percutaneous reduction, closed reduction, getting the articular block all right, putting in lag screws first, getting the articular surface all right, and then starting the entry point with the nail with the suprapatellar technique. The things don't move at all because the limb stays in extension on the table. And for a very bad type 6 fracture, this is all you need: a small incision, very small stab incisions, and one can operate early. You don't need to keep the patient in hospital or send them home to wait for the swelling to come down. This can be done early. Another type 6 tibial plateau fracture case, same way. I've just converted a type 6 into an extra-articular fracture using some K-wires and screws, and then I've started the nailing technique wherein all these difficult fractures can be nailed. This is a post-operative X-ray for this patient. Another case which has a trisegmental fracture. So there are 3 fractures in the tibia, and they can easily be nailed using the suprapatellar nailing technique. Another case of a type 3 tibial plateau fracture with a shaft tibia fracture, which would have otherwise required a 4.5 mm long plate, which would be difficult, can be added with a plate and a nail combination like we saw in the distal femur fractures. They were being added. Another case of a very low distal tibia fracture, wherein there is a fracture line going right up to the joint line. One can nail percutaneously. See here, I have changed the direction of the screw, locking screw from lateral to medial, medial to lateral. I've changed it to lateral to medial so that it doesn't go into the fracture side. And this is the post-operative X-ray of this patient. So they can be done minimally without compromising on the soft tissue condition at all. There's another case for the distal third segmental tibia fracture, and they can be nailed really well. This is a 3 months follow-up, 3.5 month follow-up, and 5 months follow-up of this patient with a good union. Another case of 56-year-old female with a trimalleolar fracture ankle, but even with a trimalleolar fracture, it is still possible to nail upon these fractures. Another case of a 36-year-old male. This is almost the extreme of nailing. It is almost like a pilon fracture. But then here, one can easily nail, put a plate onto the fibula, nail and put in some screws for the malleolus. And this is how the X-rays look. So another case of a type 3 split depression type of a fracture with a proximal third tibial fracture, where I've elevated the joint depression, put in some bone graft, added some screws, and then I have done nailing for this patient to get a good outcome. Another patient with another type 3 type of a tibial plateau fracture, where I've raised and the element, put in a raft plate, and then done a nailing for the proximal third tibia shaft fracture. And this is the post-operative X-ray of this patient. Thank you for your time.
Perfect. Any questions? Anyone? Sunil, any question?
So Samarth, can I pitch in here? It's a wonderful technique, and I think it's very useful for the fractures which are where you have a multiple fractures in the same bone, segmental fractures, the 3 fragments. What about the splayed fractures of the proximal tibia, the comminuted displaced fractures of the proximal tibia? Do you use in these cases also?
So in proximal tibia, usually I stick to type 1, type 2, type 3, and type 6. So type 4 and type 5, usually I need to plate. And this is one area where you had raised a question about arthroplasty in the future. Whatever I am doing is not going to bugger up arthroplasty in the future, because my incisions are really small and there is nothing around the knee at all. So type 5 is a difficult thing to nail, and that is where I would normally plate. Even in type 4 fractures, I would only plate. But type 1, 2, 3 tibia with or type 6 tibia, I would nail. And distal third tibia fractures or intra-articular distal tibia fractures also I would nail, because the soft tissue condition there leads to a lot of problems in a lot of cases.
That's very right. I wanted to bring this point in, that in a very badly comminuted type 4, type 5, it will be probably difficult to use this technique. But it's a wonderful technique for a segmental fracture.
Thank you, sir.
Dr. Sushrut, Dr. Himanshu seems to have one question. Can we take that before we move to Dr. Deepak?
Yeah.
Dr. Himanshu, please.
Yeah, hi. Good evening. So, Dr. Samarth, that was a great presentation. My only question was regarding your lower third and the lower fourth and the pylon fractures which we have nailed. When we have done those nailing, how do we usually just wherein we don't have too much of involvement of probably the posterior malleus or the lateral malleus, how do we make sure about the rotational stability post-op? Is there some sort of a specific thing that you're using post-operatively? When do you mobilize these patients post-op protocol?
Sir, so rotational stability, if the fibula is comminuted, I would plate the fibula and then do this nail. And otherwise, all the screws that I'm using in these nails distally have a threaded option in them, so they lock onto the nail. And the screw, it is not only an interlocking screw, it is a locking, rotationally stable screw. So it even holds on to the fragments and controls the rotational stability. And in fact, I would mobilize these patients much earlier than I would mobilize my plating patients, because any day, intramedullary implant will definitely be biomechanically stronger than an extramedullary implant.
Can I ask one question, or are we going late?
Chetan, Vicharna.
No, you showed some great cases, and I do agree for diaphyseal extensions when you have, or even low tibial fractures, this is a good technique. But you said type 6. Now, most of these have coronal elements or posterior elements. Now, how does that nail really take care of that? Because they need a buttress, and that's been now proven beyond doubt that unless you buttress, especially the posteromedial condyle, you would end up in a late flexion varus kind of a deformity once the patient starts weight bearing. And you also said that you would mobilize them early. So any special tip that you have for coronal splits along with this?
Sir, coronal splits usually come with type 4 and type 5. So type 4 and 5, I'm usually not nailing. So it is with the type 6, usually there is never a coronal split. But if there is, yes, I'm not saying that all coronal splits, I would usually buttress with a posteromedial plate or a posterolateral plate or an anteromedial plate. One of those I was buttress. Those are not the fractures that I would nail. And okay, so for a nailing technique,
you have a coronal split, you would not nail.
But if it does have a diaphyseal component, then I would probably put a plate posteromedially or posterolaterally and then do a nailing for the shaft tibia, rather than put a long 4.5 plate and then mobilizing my patient at 3 months. With this, I can probably mobilize my patient at 3 weeks, 4 weeks with partial weight bearing, toe touch weight bearing, or weight bearing as tolerated. So mobilization becomes early, the surgery becomes early, and the surgical time becomes much shorter.
Okay.
Great. Good job, Samarth.
Thank you, sir.
Move on to Dr. Deepak Agarwal, whom we were missing. Deepak, all yours.
Dr. Deepak, are you there?
Are we stuck again?
Dr. Deepak? Yeah, please start.
Yeah, can you hear?
Yes, please start. Yeah.
Okay. We'll talk about some supracondylar fracture and malunited supracondylar fracture. And so we'll start with some basic introduction, in which this is a third most common type of pediatric fracture which we face in our day-to-day practice, and it is the most commonly operated fracture. The supracondylar fracture are most common type of fracture of the elbow in children, which account for 3% of the all pediatric fractures. Supracondylar fractures are most commonly in children between 5 to 10 years of age. Most fractures are on the left side or non-dominant hand. So the surgical correction of malunited distal humeral fracture in children is challenging and complex. Traditional methods require exact wedging and dissection. The osteotomy is typically maintained with pin fixation. Internal divides are usually removed surgically once osteotomy is healed and complete. Pin fixation requires extended periods of casting to protect the osteotomy until bony union has been seen. The loss of fixation with pin is known complication. The physical examination is most important. The initial clinical examination shows pain, swelling, deformity. Active elbow movements is limited, gross deformity of the arm, and thorough examination of the limb with neurovascular examination. The main evaluation is to evaluate the distal pulse, capillary circulation, pulse oximetry, Doppler and angiography also may require sometimes. What not to miss is this impingement sign, occurring sign which is known as displaced fracture, which can cause neurovascular injury, which is irreducible. The most common Gartland classification, 3 types of supracondylar fracture. Type 1 non-displaced, type 2 is intact posterior hinge, and type 3 is completely displaced fracture. Wilkins has modified type 2 into A and B, which is 2A are extended but not rotational abnormality, and type 2B is with rotational abnormality. And type 4 is also again recently modified with unstable in both flexion and extension type. Now, angular and rotational malunion are known complication of the pediatric fracture of distal humerus. These malunions are frequently also associated with rotational malalignment. In supracondylar fracture, the incidence of these complications have been reported to be high as 50%. Modern treatment of this fracture utilizing close reduction and pinning fixation has significantly reduced this complication rate. Similarly, lateral condyle fracture can be associated with varus or valgus angulation because of the growth arrest or malunion. Children with these angular deformities may have functional limitations and poor osmosis. The other complications may include restricted of elbow flexion, tardial nerve symptoms with cubitus valgus deformity. These malunions have limited ability to remodel because the deformities are perpendicular to the plane of the elbow. Osteotomy of the distal humerus is necessary to correct this deformity. There is one technique, is a complete dome osteotomy. It is performed through the very limited posterior approach. The osteotomy is maintained by the small just fixator using 2.5 mm pin, which minimize the scarring. This method permits precise intraoperative adjustability. The external fixator is lightweight and can be tolerated in the lateral position. This dome osteotomy and the fixation technique prevents osteotomy displacement and permit an immediate range of motion. The pin care and antibiotic.
Can you straight away take us to the cases, please?
Yeah, sir. I'm on the slide, sir. This is an 8-year-old child with cubitus varus deformity. So this is the pictorial diagrammatic of the what we do is a dome shaped cut of the supracondylar region, and then it is fixed with external fixator. So the pre-op planning is there. The patient is placed laterally, and from the backside posterior, just above the olecranon process, the pin is fixed, and then we can make a dome shape. Through this zig, we have to make a small incision and dome shape cut. Through the same incision, multiple drill holes is done in the dome shape, and then these drill holes are connected with the osteotomy. And then by gently rotating the and correcting the correction, we can find the correction, and then it is fixed with one lateral pin which crosses through the fracture site, and 1 or 2 pin distally and 2 pin proximally. Both can be this can be connected with just fixation. So this is the case here. We can see the good union and the good function. The mobilization on the pain relief, pin track care, X-ray at 2 and 4 weeks, fixator removal at 4 to 6 weeks, POP, and exercise protocol. So we can find the good results here. We can see the flexion end as compared to the other hand. There are other osteotomies also. This is a simple lateral close wedge osteotomy, 3 pins above, 3 pins below, and corrected the deformity and fixed with external fixators. These are just to show there are other osteotomies described in the literature. But using a simple lateral osteotomy and or AO external fixator or dome osteotomy, the just fixator is an effective method of achieving good correction and precise control in the supracondylar humerus osteotomies in children. Various wedge osteotomies have been described, which are just shown here. Lateral condylar prominence, medial approach osteotomy, supracondylar medial approach, a new osteotomy of cubitus virus. These are other osteotomies described in the literature. One is this open technique osteotomy where this wedge is removed and this wedge is removed, and this bone part is fixed over here so that there is no translation here. So which was described in the literature. So I see this small piece of bone is wedging here. So this series of demonstrates that an interlocking lateral wedge osteotomy with the parallel lateral pin fixation can provide reliable correction of the varus and extension deformities with a minimal complication rate.
Okay. With this, does anyone have any question? Unfortunately, Deepak, I have to stop you.
No,
so
sure, sir.
can
I've
ask
already finished.
Questions, please. If you can unshare your screen. Chetan, any questions?
No.
Swanendu? Wake up, man.
No, I'm here. Because I'm doing very little amount of pediatric thing. I don't have many experience. Usually when I started doing this thing, we are classically not doing the dome osteotomy because these are small bones and very hard to replicate whatever is given in the diagram. So we are all been trained with the French, modified French and all. So at best I have done only the modified French. I have never done the dome.
And only during MS Orthopedics exam, we used to know about that pentalateral osteotomy. And I still remember the name Laupatta Raka same, pentagonal osteotomy.
Yes. At best, I have only done the modified French, never done with that.
I agree. Any questions to our panelists? Rajiv, S.K. Agarwal, sir, Himanshu and Saurav? Any questions from them? If not, let's move on to the next one by my good friend Srinivas Kasha, who is going to present to us on positioning technique in management of complex proximal tibia.
Yeah.
Udit?
Dr. Srinivas Kasha is working as a senior consultant orthopedics at KIMS Institute, Secunderabad. Obviously, his heart lies as primary consultant for pelvic trauma surgery, serving as a national faculty and one of the initiators. This long history of trauma experience in nationally and internationally, we welcome him. Dr. Srinivas Kasha.
Thank you, Sushrut sir. Thank you, Dr. Sudhir.
Requesting if you can put your video so that.
Yeah, sorry, I'm. You must excuse me. My video is not working for some reason.
Absolutely fine, sir. Okay.
Thank you so much. So I just want to take you directly through a case first. So is it visible?
Yes,
sir.
Yes, you're good.
Yeah. So here is a 35-year-old male with a road traffic accident, a two-wheeler bumper injury kind of an injury. And this is the situation, and soft tissues had blebs and that is settled now. And I want to show you the CT scan. So please, any one of you can comment on the, pattern of injury or, classify this fracture.
What is the soft tissue situation?
Now it is settled, sir. It's been 15 days. Point that, soft tissues to manage soft tissues, span it. I got that point. And where to start our fixation is my next question.
It is always
it is not just the soft tissue, Dr. Kasha. I believe that it also helps you plan the surgery really well, and what you're going to get intraoperative with traction. Right now, we don't know how the fragments are going to behave. And when we go in, we are venturing into an uncharted territory. If you do a simple spanning and then do a scan, you know how the fragments are going to fall, and it makes your job a lot more easier. You will spend a lot less time in the OT.
Srinivas, there is another view called end-on view of the tibia. If you can, have that end-on view, you will come to know the fracture geometry like a Low's classification as per the quadrant, So all four quadrants are fractured. Anyway, you can
correct. Yeah. So in this you have all the four quadrants.
So first you start with the posterior medial.
Yes.
Always on the posterior medial. Then on the same you have to modify a little bit incision so that you have a very small area to put the buttress on the medial side, on the anterior medial fragment, and then go for a lateral raft plate.
Right.
No need to put even there is a cartilage is just angulated, so you can use a raft plate on the lateral side. Make sure the plate length is little bit either must be longer than the maybe a medial is shorter and a lateral will be longer. And there you can add one or two latch screws for the tibial tuberosity fractures, so that you can have a good stability. So what you have to give is absolute stability because it's a intra-articular fracture.
Perfect, sir. Perfect, sir.
I would use 3 plates here: posterior medial, anterior medial small radius plate, and the raft plate on the lateral side.
So because there is a coronal split of medial condyle, right?
That's right.
Yeah.
And we have to compress with the latch screw first because there is a widening of the tibial plateau. So there will be a stress on the lateral collateral ligament also. So we have to reduce the girth of the tibia so that it is because of the lateral femoral condyle rammed inside. So that is girth has also increased. So there will be an injury to the lateral collateral and capsule also. So you have to reduce that girth so that you can have a good interfragmentary compression before going for these platings.
Yeah, and just a tip to reduce that girth, you have to actually elevate what has gone in. Correct. And most often you will find the meniscus.
Lateral meniscus is also gone inside.
But
yes,
then,
another one thing,
the position of the limb and position of the patient during surgery.
It has to be supine because you have to address both the medial and lateral side with both the sides open. Because otherwise you cannot do the thing is that you have to apply the external fixator during the operation also, because unless you distract, it is very difficult to reduce the fragments.
Correct.
Yeah, I would also
you meant to say femoral distractor.
I would also do it in a
whatever, not the femoral distractor. You can put the same distractor in the modular mode so that you just distract the fragment so that everything falls back, because you have to reduce the ingoing femoral condyle from the tibia. You have to disengage that, otherwise you can't progress.
Right.
Srini, now a couple of points before you go ahead.
Yes.
Number one, it's very, very clear that you have to put an external fixator today for all these comminuted 4-zone multiplanar, multi-directional displaced comminuted fragments. Because unless until you put an external fixator and distract, your CT scan will not give you details of those intramedularly sunken fragments in the intercondylar zone.
Correct.
It will also not tell you about your lateral meniscus, which usually gets embedded.
Correct.
Now, once you do distraction and you do a CT reconstruction, as Sunil rightly suggested, you have to have that end-on view and calculate. Okay, Lau's classification is now old. We follow the modified Schatzker's classification now. That will give you an exact idea how much displaced your 2 ends of proximal tibia are gone, because you need to reduce that width completely. Unless until you do that, your lateral femoral condyle and medial femoral condyle are not going to sit on the place where it is designed to sit in proximal tibia, because if it grows more, your patient will have deformity, your patient will have early pain and lead to early TKR. So to reduce that, reduce these 3 things, you have to reduce that lateromedial width of proximal tibial plateau that you can only judge after distraction and after getting an end-on view of proximal tibia. Coming to approach, always posteromedial first if you are going to do that.
Right.
Number 1. Number 2, position can be a floppy lateral or posterior, because in supine position you cannot put a posteromedial or posterior plate in supine position, because this fragment will always get reduced in complete extension. Perfect. If you take patient in supine position and flex it, your proximal posterior medial fragment is going to get displaced. It will reduce in extension. You hold it in extension, and then you make it figure 4 or a floppy lateral if you are using. But go where the gold is. So if you are going to fix posterior fragments, go posterior approach, posterior position, fix it, then change the position to supine. Always place your external fixator distractor laterally, so that in supine position or prone position, that external fixator will not cause a hindrance. Let's move on.
Yeah, perfect, sir. So these fractures, they usually get reduced. The coronal posterior medial coronal fragment get reduced in extension. That is one point which is very, very important, even I feel. And so somehow it's not moving. Yeah. So the components of injury here are lateral condyle with depression, medial condyle, the coronal split, tibial tuberosity fracture, and of course fibula fracture. And we have already discussed that.
Can I stop you, Srini, here?
Yeah, yes, sir.
Go back to the slide.
Okay.
Because I'm currently facing a medico-legal case of similar fracture who had a primary lateral popliteal nerve injury.
Yeah.
Patient also had a compartment syndrome. So I had to decide to release that lateral popliteal nerve which was getting injured, which got primarily injured in that situation. We as trauma surgeons think that patient is not moving the leg because of pain, but we have to very intelligently observe whether there is with this kind of an injury which is at the neck in the fibula. There is a significantly high incidence which is underrated of primary lateral popliteal nerve injury, which can show up later and cause a havoc in our life. So please make sure that if you see this picture of fracture of fibula near the neck, make sure that you document whether primary lateral popliteal nerve injury is there, whether compartment syndrome is there or not, whether the swelling is reduced, etc., etc. Okay?
Perfect, sir. Important message.
So that is the reason you will come to know once you fix it, because you have to wait for 4, 5 days, 6 days, 1 week to get the swelling down. So you will come to know whether there is a compartment syndrome or a lateral popliteal nerve. Once the swelling comes down, the patient start moving it.
Correct.
So like it's already been discussed, floppy lateral position or supine position as somebody has advised. But if it is supine and if you flex, there is a chance that all these fractures, they get reduced, especially posterior medial fragment in extension only. So no single position can address all these things. And this is the picture sir was talking about, Luo et al.'s classification. And so the sequence which I took here is same thing as described, posteromedial first, and then fixed with anteroposterior screws as there is a coronal split of medial condyle, and then avoiding screws into the lateral condyle because there is a depression. If you pass a posteromedial long screw from posteromedial corner, it might interfere with your elevation of the fragment when you are addressing on the lateral side. And the challenge is changing of position. So this is exactly the problem that is going to happen if at all we use a long screw. And two positions will cause an issue here. So is there any way by which we can address it in a single position? This is a position which I usually use. I break the table and hang the other limb, something like this, and I'll keep the limb on the opposite, towel. And in extension, you get the posteromedial condyle reduced, and I start my work from that corner. And the limb won't come in your Shyam view. And you can put a posteromedial plate as well as screws from posteromedial corner, like in this picture. And of course, if there is any lateral condyle or posterolateral condyle involvement also, you can address both through this particular single position. And the sequence of steps which I have used, posteromedial plate first, followed by anteroposterior medial condyle screw, and that is followed by elevation of the condyle on lateral side, grafted it, and have fixed tibial tuberosity also, and then made wrapped screws. That's the final outcome, and that is 5-year post-op. So my idea is to demonstrate this particular positioning technique wherein you can address these complex tibial fractures, proximal tibia fractures, with a single position wherein you need not change your position of the patient, and interference of your posteromedial long screws won't happen even in the depressed or a segment, and you can address, you can interchange if you want once you elevate the lateral condyle. That's it, sir. Thank you.
Very well handled difficult fixation in a very difficult fracture. Now, did you use the external fixator also in the post-op phase?
No, sir.
Okay. I'll just add two things here, Sushrut. That number one, that many a times you find that tibial spine is also fractured. So at that, if you see that, and that you can see by the anterior, the two incisions, if you start with the position, keep the patient supine, use a lot of drapes to flex it to almost 70-80 degrees. And then when you want to fix the posteromedial fragment, you can always extend the knee and keep the knee in the lateral rotated position. And then you can address the posteromedial condyle. The incisions, one incision, the anterior incision, lateral base, that's what I normally put in these cases, and one under the second incision for the posteromedial condyle. And always see that if you have a tibial spine fractured, then use a fiber wire and fix it up with the plate. So that probably is a good technique, which may be useful for some times.
Can I just add on to something which I had an experience with? I am Dr.
Yeah.
Hi. I think my limitation of using a posteromedial plate is because if we follow the Lewis classification, it does say that the plate should cross the apex of the fracture. The plate should cross the apex of the fracture. So I don't know whether this fracture, which has got a significant dead posterior component, how do we buttress that apex to the metaphyseal or diaphyseal bone? Using this posteromedial plate in a young patient could be a simpler task, but if a patient who is about 50-55 years of age, that could be really challenging, because then the bone is really comminuted at the metaphyseal diaphyseal junction also. The second thing is that I actually experienced a very similar fracture pattern, but in a 60-65 years old male, and he had a significant injury, and we tried doing a ORIF initially using the posterior fixation, but the plate just didn't hold. And the reason was that there was a significant loss of the cancellous bone medially. Medial bone is very strong. It's the lateral bone which is soft and it depresses. In that fracture, there was a significant loss of the medial plateau, and the plate didn't hold. And in those cases, I think what the mistake I did was I did not follow the CT scan enough. So if we find in those cases there is a significant chunk of loss of the structural integrity of the cancellous bone, and a laser fixation could be a saving grace in those fractures. So this is what I wanted to share by my experience in such a fracture.
Any more comments, observations by any of the faculty?
Sir, if I can add something.
Yeah, sure.
So I get a lot of these patients. I usually operate them in the supine position. If they are less than 100 kgs of weight, I get patients up to 150, 160 kgs of weight as well. Then it becomes a real challenge. Up to 70, 80, 100 kgs of weight These patients, I do them in supine position without the other leg going down. What I do is I use the arthroplasty bolsters on both sides of the pelvis. So if I tilt the table to both the sides, so when I'm operating upon the lateral or the posterolateral aspect, then I tilt the table towards the medial side. And if I'm operating on the medial side, I tilt the table onto the lateral side. I even sometimes put a belt onto the patient on the pelvis so that the patients don't go anywhere. So with the patient stable, with these 4 bolsters on the pelvis and the upper thorax, I can rotate the table on either side. But for the posteromedial, in fact, I can even go posterolateral in the supine position with the leg in slight figure of 4 and externally rotated and the table slightly tilted. And if I have to address the posterolateral fragment from the lateral side itself, so I use a lateral incision which I can slightly extend upwards to the femur. And then I use the approach described by Dr. JKO, where you can do a posterolateral, extended posterolateral approach, and one can address both posterolateral corner and lateral corner at the same time. So supine position, I have all the options open. I can go to the posteromedial fragment, medial fragment, anteromedial fragment from the medial side, lateral fragment, posterolateral fragment from the lateral side. It really becomes easy and saves me a lot of time, because in our government setup, if I have to do a patient prone or do some special position, it takes at least half an hour or 1 hour of extra time. All my type 4 tibia fractures also I do in my supine position itself. Even dead posterior fragments, I usually do them in supine just to save that extra hour.
Okay, perfect. Thank you very much. Because of the paucity of time, I think we'll need to jump to the next case. Srini, great case. Good.
Thank you so much, sir.
Dr. Jyoti, can you just put that slide?
So who's next in the line?
Dr. Sunendra Sumanta, sir. Yes, sir. So Dr. Sunendra Sumanta, sir, will talk about the pilon fractures. Just a small introduction about Dr. Sunendra Sumanta, sir. He has a very strong background in terms of academic workshops and in the paper publications. He's been very much profound in talking about the fellowship from Singapore General Hospital also in the past. I welcome Dr. Sunendra Sumanta, sir, for his talk.
So you have to unshare, otherwise I cannot share from my side.
Can you try again, sir?
Yeah. Once you unshare, I will be sharing.
Yeah, it's unshared, sir. It's unshared, sir. Yes, it's perfectly fine, sir. We can see the slides.
You can see the slide, huh?
Yeah.
Yes, Swananda. Go ahead.
Yeah. So as it is a great honor to interact with the old friends and really on this great platform. And when we talk of the pilon fractures or the fractures around the ankle, it is not only the fracture, it has to be the soft tissue, how we deal with the soft tissue, the white blister or the red blisters and all the, basically it is an internal degloving sort of scenario. So we are all been seeing this. So the same protocol, whatever we are discussing for hour long, how to go ahead with the tibial plateau fracture in the knee, it is same module is true for it. We have to span it, then scan it, and then go ahead. So I think even this sort of simple looking fractures, if your soft tissue trauma is great, then you have to span it. This is mandatory in our institute, because unless you span it, then you go ahead with the scan, then you read your fractures. So sometimes, because nowadays we are dealing with many proximal tibia fractures, and we have learned how to deal ahead with the posteromedial or the posterolateral fragments of the proximal tibia. Same is true for your distal tibia fractures. Unless we do understand how to go ahead on the posterolateral side on the tibia or the posteromedial side, is basically it is a 360-degree approach to the distal tibia. So you have to make sometimes the patient prone so that you can go ahead with your posterolateral side, so that you can plate the fibula, and also you can address the posterior side of the tibia. So this is a very simple approach. Only thing is that you have to be very cautious that you are not injuring the sural nerve, because either side of the peroneal you have to work. If you are on this side of the peroneal, you are basically on the posterior side of the tibia. And before choosing the posterolateral side incision, you have to take care of what Sunil was telling, that you have to see the axial cuts, so that you know from which side, whether the posteromedial side or the posterolateral side, you can best address the posterior fragment of the tibia. So because this was a posterolateral sided thing, so I did from the posterolateral side. You see, this is the peroneal, and this is the posterior part of the tibia. So once you see this, and once you elevate, once you free the space, you can see the whole back of the tibia on this side. So this is the way you can apply the 3.5 recon plate on the back side, and also you can plate the plate. Now you see the Shyam picture, you can buttress the fragment on the back of the tibia from the posterolateral side. And once you buttress that, you can put the plate on the fibula, and you can then go ahead with your medial malleolar fixation. So whenever you see the distal tibia fractures, it is like the proximal tibia fractures. You have to understand the whole 360-degree approach. Unless you understand the posterolateral exposure or the posteromedial exposure, you cannot do that. Same thing, this is another one case. This is this case we took from my friend Dr. Rajiv Chatterjee, because this was discussed during the one webinar. You see, this is a really complex distal tibia fracture. You see, reduce the skin. This is the CT scan. Unless you do the X-fix, you cannot do justice. Now, you have to see this sort of axial cuts. And this is the die punch fragment. If this is the die punch fragment, can you see that? And the die punch fragment and this fracture line will dictate you which sort of anterolateral or the anteromedial incision you will take. As because this fracture line is on this side, you can choose from this fracture line the anteromedial approach. But if you see the die punch fragment is here and the fracture line is here, then you have to take care of the anterolateral incision. So this is the way how you see your axial cuts. Then you take the patient's position approach, pronar supine, posterolateral or posteromedial implants. And then you have to buttress the fragment like this. Unless you see the axial CT scan, you cannot judge your approach. If you don't take the proper approach, you cannot reduce this fragment. So this is both the side was approached from the posteromedial and posterolateral side. This is another one. You see this is another one complex one. You see the CT scan, and we can buttress it if you approach from 360-degree approach on that. And so you have to, the only thing is that you have to take care of this sural nerve, because it is just 7 centimeter above your tip of the lateral malleolus. Only you have to work on either side of the peroneal, and you have to take care of the peroneal artery. This is the Haraguchi classification. Forget about that. It is a big fragment on the lateral side, so you have to go from the posterolateral side. If this fragment is on the medial side, you have to go from the medial side. It is as simple as that. So this is another one posteromedial approach. You can see this is the line. This is the T posterior tendon. And once you take the T posterior tendon on the back side, you can take care of the neurovascular pedicles. And the whole posteromedial side is open. So this is the way you just cover the skin, the soft tissue. So this is the way you have to see the posterior side. You have to judge the CT scan axially. Then only you can see which posteromedial or posterolateral, anterolateral or anteromedial incision you have to choose. It is just like the same thing what we do for the proximal tibia. So points to, you just remember that crossover, there is a big crossover between the ankle and the pylon fractures. You have to meticulously see the CT scan, specifically the 2D scan, because 3D scan don't give you the much of your information. You have to position the patient prone or supine, and then you have to choose categorically the proper approach. And you have to, these are the very simple implants. You don't have any fancy implants for these pylon fractures. Thank you very much for your kind and patient hearing.
Swarnendu, can I ask you something?
Yeah.
Just pinpointedly answer me, because I have tried lots of plates. Which is the best plate you have found for fixing posteromedius?
It is a 3.5 recon and the distal radius plate.
Distal radius plate. Okay.
But Sushrut, now you have anatomic posteromedial, posterior plate.
Which company?
Synthes has a variable angle.
I think it is from the Smith and Nephew also. There are some plates are also there. And also some local company, they are making these posterior plates. But I think the distal tibia plates are beautiful.
Yes, Synthes, Smith, Nephew both have. And even quite a few Indian companies are coming out now.
Yeah. Even sometimes for the juniors, you can take your hand set or the distal radius set.
So that I'm using. As of now, I'm using distal radius set. I have also used dental people, they use for maxilla, that mesh. That also I use because sometimes, though you have postero lateral component, there can be some element posteromedially which usually plates escape. So this mesh put on the entire posterior side covers the posterolateral component and posteromedial component also. So that's
yes,
what
that's why I repeatedly stress upon that whenever you deal with the distal tibia fracture, please see the axial cuts.
Absolutely.
Because that gives you the best information. You can choose the approach from there, and please, from next day onwards, you see where is the dipart fragment, because that is the main fragment that you cannot reduce. So unless you take the proper approach, you cannot never reduce the dipart fragment.
True, absolutely.
It's very well done fixation. Only one thing I like to add here, that sometimes I use the cannulated 4mm screws, and they are very useful in holding these fragments sometimes.
No,
in
my last case, I have only used the cannulated canceller screw with the washer, because these are real beautiful. Because if it is less than 20% fragment, you should not put the plate. Even you can put the washer as a anti-glide washer sort of thing. If you put it on the apex.
Swanendo.
Yes.
Don't talk of percentage now. We all know that.
No.
There is no relation of percentage now.
Percentage is not at all important. Whatever might be a small rim fracture, you have to fix it.
Because coming from your mouth, it matters. So don't say that.
No, as because he is telling of the cannulated canceller screw. Even for the small fragments, I tell you that you have to fix it.
Absolutely. And you have to use plate, and you have to put that posterolateral oblique ligament in position. Otherwise, even with a very tiniest osseous fragment and this ligament gone out, it will create an unstable situation.
Basically, washers, they act as a single hole plate.
Absolutely.
Yes, single hole plate.
The important message here should be that we have to approach them from posterior side and not from antero-posterior when you're doing even with only screws.
Yes.
Antero-posterior screw is out, Chetan.
Yeah, antero-posterior is out. Is out completely. Okay. Thanks, Swanendo. Great case, buddy.
Thank you.
So let's move on to our Guru, Dr. K.K. Mittal, sir. Sujit, you want to?
Yes, sir. So once again, I look forward that Dr. K.K. Mittal, sir, has been in the trauma surgery since last 37 years, have numerous articles published in international national journals, and he's also in the editor board of Journal of Bone and Joint Disease. His topic is biomechanics of extramedullary implant for proximal femoral fractures. I welcome Dr. K.K. Mittal, sir, for his presentation.
Thank you. शेयर करो भाई कैसे करना है मुझे बताना शेयर स्क्रीन शेयरिंग अच्छा ठीक है So once again, good evening. My presentation is extramedullary implant biomechanically inferior to intramedullary in unstable proximal femoral fracture fixations. I will confine myself to PFLCP, that is pre-contoured plates. Pre-contoured plates are widely used to fix fractures of various anatomies, and they are yielding good results. But we are hesitant, most of us are hesitant to use this in this zone because it is a highly stressed zone, high deforming forces, cantilever anatomy, and transitional architectural change from cancellous to cortical bone in trochanter to subtrochanteric. We prefer nails because they have a short lever arm, less stress on the implant, and they are load sharing, permitting early weight bearing. Even the all nail constructs cannot be load sharing because minimum 50% cortical contact is required for weight bearing. Even some plate constructs can be load sharing depending on the geometry of fracture and type of fixation. PFN was introduced in late 80s, and since then it has gone under several improvisations, and still it is under modifications. Gamma nail, TAN, integrated TAN, PFN-A, improved PFN-A, expandable nail, Halifax nail, medial sustainable nail, and TFN. They are few of the presentations. Even for the lateral wall, we need augmentation either by the plate or the wire. In 2017, improved PFNA walls introduced, having an additional screw at 110 degrees, making it a triangular configuration. And as we know, the triangular configurations are most mechanically stable constructs. Stress distribution changes from a point and a line to surface, as a stable trigonal path prevents early failure. In 2019, the medial sustainable nail wall was introduced with a kickstand screw, and it is a mechanically better implant. Once a wise man said, study principles, a mind that follows principles will do the best with any implant. And the principle is stable reduction. Obtain it, it is surgeon dependent, maintain it. The bone quality, the degree of comminution, and the integrity of lateral wall are to be addressed by the implant for its maintenance. And as we know, there is a race between fracture healing and the implant failure. So implant should be mechanically strong enough to withstand all the deforming forces. Know your implant well. Screws at 95 and 120 degrees, they support the cantilever. Screw at 135 acts as a kickstand. They prevent varus collapse. Holes are in different sagittal and coronal plane, providing tripod support to subchondral bone. Screws are self-drilling and self-tapping, preventing mechanical failure of bone. PFLC provides tension band effect as it is applied on the lateral wall shield. It is a single beam construct and gives torsional stability. PFLCP gives a benefit of all the variants introduced so far. Screw at 120, 110, the locking, shielding of the lateral wall. Screw at 135, providing kickstand effect and giving rotational stability. Some examples, they can be done with nail also easily. There's nothing great in it. Done biologically. Subtrochanteric segment, the aim is mechanical alignment, not true anatomical alignment. Because if we go for anatomical alignment, most often we have to go for open reduction, stripping soft tissues and compromising osseous and vascular supply. It preserves fracture biology. As we know, the reaming causes endosteal damage to the vasculature, and that requires 6 to 12 weeks to recover. High velocity trauma in a 40 male fixed biologically by PFLCP, showing good union at 32 weeks. Another example, 28, high velocity trauma, preoperative, postoperative, done biologically. At 14 weeks, fracture alignment is maintained, implant is intact. At 40 weeks, sound union. Coming to the non-union segment, we did FLCP augmented by narrow LCP, and this paper was published by us in Indian Journal of Orthopedics last year. Who fails, the surgeon or the implant? Naturally, implant fails, but who is responsible for it? Surgeon. Broken or bent implant is a consequence of non-union. Stress concentration due to cyclical loading at a point makes implant vulnerable to fail. Failure is insidious. Average time required is 10 months. So every surgeon should take care of it, that if fracture is not healing, should go for bone grafting or augmentation or both. Various authors have reported the percentage of nail breakage from 0.2 to 5.6%, but no such data was reported for PFLCP and none in our series. I failed, not the implant. Highly unstable fracture seems to be fixed nicely. But at 1 month follow-up in a 76 female, there was a varus collapse and backing out the screws. Careful, immediate post-operative X-ray revealed gap at the fracture site and inadequate locking of the kickstand screw leading to varus collapse. In fact, in a cadaveric history, the author reported no breakage of PFLCP in cadaveric and synthetic bone study. As we know, the stress concentration is at the leg screw aperture in the barrel or the distal barrel taper, while in the case of a plate, stress is distributed between two screws adjacent to the fracture site. So in the case of nail, there is a stress concentration, while in the plate, it is a stress distribution. As we know, the deforming force is equal to load multiplied by the lever arm. And in case of a nail, lever arm is short, and in the case of plate, it is more. But single beam construct is 4 times stronger than the conventional plate. I propose a hypothesis as 3 screws in head and distal screws are on line of mechanical axis. Being single beam construct, it's taken as 1. Effectively reducing lever arm, hence deforming force. So gives enough strength to withstand all the deforming forces. Here, author concluded that the biomechanical features of modified anatomic plate were similar to those of PFN. Finite element methods and biomechanical tests revealed that the map is associated with both intra and extramedullary fixation features. Enough though, the load was applied as the extramedullary stimulus. We permit non-weight bearing from 3rd day, partial incremental weight bearing after 4 weeks. But as our experience and confidence grew, we have started early weight bearing from 3rd day in young adults with minimum comminution. I have done so 135 cases in the last 6 years. And the thing to mention is that no blood transfusion is required and no breakage of implant, no cut through or cut out were reported. In one case, one has to do revision because of her age. There was a loss of reduction, and 7 patients, they reported varus collapse. Edge over PFN, no large hole in the bone avoiding stress riser, no damage to endostal vasculature, biological fixation in subtrochanteric and proximal femur extensions, resists axial and bending stresses better, no iatrogenic damage to abductor mechanism. No implant can convert unstable reduction to stable reduction. PFLCP is a good implant, early weight bearing in agile patients. Stable reduction is prerequisite for success. They are my grandchildren. One is intramedullary, other is extramedullary, and both are very dear to me. Thank you very much.
Great, sir. Thank you.
Thank you.
Any questions to Mittal, sir? Chetan? Is Sunil gone?
Yes, sir. Dr. Sunil is not.
Can I ask a question?
Sure, sir. Sure.
This proximal femur locking plate, which was initially introduced by Synthes, had reported a lot of failure. And in fact, the breakages and failures were so high that they stopped marketing it quite soon. So what, according to you, went wrong? And is this plate something different, or?
It's practically the prototype of Synthes only. Mm-hmm. And they have restarted launching it. Soon they will relaunch the Synthes paper, this plate.
Okay.
Basically, it requires a little understanding to do it.
Okay. Because currently the only plate which is actually successful is the Smith-Neville plate, which is very, very strong and has multi-directional and multi-diameter locking in the head, neck, and the shaft. So that is what even I use for revision surgeries mainly. But otherwise, there are no good plates available for proximal femur.
I personally use it as an accessory to my intramedullary fixation. So I do intramedullary fixation. Mm-hmm. And sometimes when I want to accessorize that primary implant, then I put this plate with less number of screws. But as Chetan, you rightly suggested, they are multi-planar, multi-angular screws proximally and mesonail technique distally. So that's how I do it. I have not been brave enough to use this as a single implant as on now because of the reports. But Mittal sir has shown terrific results.
Yeah. So that's why I was asking whether it's a different prototype.
So this plate is a very simple plate and it's from Nebula only. and very, very cost effective.
So it's a copy of Smith and Nephew, yes, sir?
It's a copy of Smith and Nephew.
So multi-directional screws, no? In
multi-directional. Yeah, multi-directional screws. And they give a good purchase. They are self-drilling, self-tapping. So even in the osteoporotic, osteoporotic bone, it gives a good hold.
Good purchase.
Dr. Mittal, if I can ask you a few questions here.
Sure.
It's a wonderful presentation. My question is that in most cases, because they are the obese patients, osteoporotic patients who have the trochanteric fracture, when you put an intramedullary nail in a comminuted fracture, when do you advise the weight bearing? The early weight bearing probably is one of the big problem. And that's why we as arthroplasty surgeons have started talking about the bipolar arthroplasty in the first stage itself. So what is your opinion between the fixation versus bipolar in an elderly population? Elderly means 70 plus.
Basically, the best thing is you have to salvage the hip. And when the fracture is such which is beyond repair, then we go for the arthroplasty. Otherwise, the first option is fixation.
Would you say that in a very osteoporotic patient, probably a bipolar is a better option?
When there is a chance of failure, definitely bipolar is a better option. Right. But it's not the first choice.
Very right.
Sir, can I even add to it? So to answer Rajiv sir's question, we have been mobilizing all the nailings toe touch from day one itself. In fact, we have started a series and a study which will be soon published, that aggressive mobilization out of the bed for a really geriatric age group which is beyond 80 years. And if you start toe touch weight bearing from day one for intramedullary nailed patients, they do pretty well if you have reduced the fracture well and you have been able to nail it nicely. That has reduced the number of arthroplasties dramatically in my institute. In fact, nowadays for any intertrochanteric fracture, we do not do that coxofemoral bypass, which was the favored modality of treatment in these really geriatric age groups. And nowadays you have augmented TFNAs also, so you can put cement through the nail into the head, and there you can. It's even suggested to start full weight bearing, sir.
Right. So what are the indications for a in the first stage itself, the primary bipolar hip arthroplasty, in the opinion of the panel here?
I would keep it for, obviously intracapsular ones and the basal ones, and maybe terribly porotic or...
No, if we focus only on the trochanteric fractures.
Basal fractures, severely porotic fractures, severely comminuted fractures, but even then, nowadays, that's a questionable indication, and of course, pathological fractures.
Right, of course.
Yes, Rajiv, I think the coxofemoral bypass in the trochanteric fractures needs a brave surgeon, because Sushrut has told this is you need some amount of brevity for doing this, because if you can't relocate your greater trochanter, certainly you'll be finding a dislocated hip the next day post-op. So I don't have that much of guts myself. I think Chetan agrees on that. Nowadays we are flitting around from the coxofemoral bypass again to the all sort of the proximal femoral nails. There's a lateral buttress plate and augmenting with the cement. That gives a good slip to me, Chetan and Sushrut.
Absolutely.
Excuse me, sir. Dr. Samarth Pittal wants to ask question.
Yeah, Samarth.
Sir, my question to you is, in these patients over so many years, have you faced more peri-implant fractures in your series? Because intramedullary implant also has the advantage that you can bypass the whole femur and it stays within the canal. So there is no stress riser. In your cases, most of these patients are osteoporotic. So have you faced increased chances of peri-implant fractures?
No, luckily I have not faced any peri-implant fracture, and even no non-union, no revision except in a case was required. All fractures they united, and there was no peri-implant fracture.
And sir, I just want to make a small comment on that weight bearing. So I don't remember since how many years, but definitely more than 5 to 6 years back, we completely shifted to full weight bearing for all these patients, not even toe touch, because there are very good amount of papers which say after 65 years of age, any mobilization is full weight bearing mobilization, nothing short of that. And we weight bear all our patients the very same day evening, or if it is late, then it is the next day. And we haven't seen much of any failures in the last 5 or 6 years of our practice. And we do more than 400 to 500 cases of these hip fractures every year.
Samarth, I agree that most of these patients at this age, when you mobilize them, it usually is the full weight bearing. It is, even if we say that you do a partial weight bearing, but they are not able to do it because neither their hands have the strength nor the legs have the strength.
So I would agree with that. It's almost full weight bearing.
Right.
Most of the elderly patients, they are not agile. They are not in that shape to stand and move.
Hop around,
even psychologically, they fear.
Right.
They are not ready to move.
Okay. So, friends, to sum up this discussion, let me pitch in my 2 words on this topic of unstable trochanter. So, Rajiv, when we are talking of this unstable trochanter situation, now with CT and 3D CT reconstruction, and I've published this in Injury way back, some 2 or 3 years back. So we are talking of unstable trochanter, posterior wall fracture. We are talking of lateral wall deficiency. This creates an unstable trochanter situation. And now we are talking of 2 population: elderly, senile, osteoporotic population, younger population. Younger population, definitely reconstruction is required. And then we move to coxofemoral bypass as Swadhendu suggested. But even then, those patients being treated with primary cemented or uncemented bipolar in this unstable trochanter situation, elderly population required reconstruction of the trochanter, despite of you replace the femoral head. Because if you do not reconstruct the femoral head, let me finish, Rajiv. If you do not reconstruct the trochanter, if you do not wrap up the posterior wall and lateral wall with either a surcharge wire technique or putting a hook plate on the lateral side, these patients had some amount of issues in terms of dislocation rate, very high, limp, abductor limp, especially after some time. So we have moved back to, as Swadhendu and Chetan suggested, even in elderly population, trying to do some kind of fixation and wrapping up the trochanter as a single piece and improving on their gait pattern. Because this gait is the issue. The gait, if you do not create one intact lateral wall and trochanter as one piece, they have a huge abductor lurch. So, but the advantage in this situation, which we have found, is we don't have to open so hugely as is required in arthroplasty. The morbidity tends to be less. The mortality tends to be less.
Yeah.
But of course, I totally agree. Despite of all this, in a hugely badly shattered trochanter, the only option remains a modular bipolar. We prefer modular bipolar, not total hip. Even as die-hard trauma surgeons, we tend to do that. But one has to repair the abductors. One has to repair the posterior wall and take care of the lateral wall deficiency. Yes, Raju.
Very right. It's very right that even if you do a bipolar in an elderly population, and you rightly suggested in a comminuted posteriorly and laterally, you have to replace the reconstruct the trochanter. If you do not reconstruct the trochanter, then there is a huge gluteal lurch, and probably in some cases you will find that the hip gets dislocated. And one thing I'll just say one sentence about the size of the incision. If you have to do a bipolar prosthesis in these patients, the better approach is open the area through the fracture site, and then it is very easy to explore, and you can do it with a very small incision in these cases.
That's coxofemoral bypass.
Yes,
Correct.
yes.
Okay, so we come to end of this session. I would want to thank Dr. Reddy's and my eminent fellow colleagues from all over the country to be with me in this articular, peri-articular fractures storm that we had last 2 hours. Thank you very much. Hope to see all of you someday, somewhere, very, very soon. Over to you, Dr. Sujit and Udit.
Thank you, Sushrut. Thank you, everyone.
Thank you, son. Thank you so much, all of you, for a part of such a wonderful discussion, specifically talking such interactive cases online across India and having great insights coming out of it, and wonderful learning for us also, and understanding the perspective of orthopedic experience in current COVID scenario. And once again, we would like to meet you, all of you, one-on-one. Now physical things have been now started going up. And once again, thank you so much, all of you, and have a great weekend, sir. Thank you, all of you.
Take care. Thanks, everyone.
Bye-bye.
Bye-bye. Bye-bye.
Thank you,
everyone.
doctors.
Thank you, everyone.
Thank you, everyone.
Bye. Thank you, Dr.